Welcome everyone to the webinar tonight. I'm excited to share just some information about ReVIVE crowns and my experience placing them and some tips along the way. And be remiss without thanking the NuSmile team. So again, Alexandra and Brittany, thank you guys. And thanks everyone in attendance. I know there's an opportunity cost for everything, so I appreciate you spending the next hour or so just learning about NuSmile crowns. I really enjoy placing them. In the past year, they've been sort of a bright spot in practice, and I've enjoyed learning the technique to place them. And I genuinely think that they make children's lives better, which is a bold claim, but we'll dig into that and show you some reasons why. So a little about me. I grew up in a small town in North Carolina. It's unverified, but I think I hold the county record for kicking a soccer ball against a wall. Education, I went to undergrad and dental school in Chapel Hill, and residency I did in Richmond, Virginia at the Bon Secours St. Mary's Hospital program. Following residency, that was a picture of me in the late 80s. And picture of me now, I still feel like the crying kid on the inside, but it just comes out in my hair now. But it in private practice in Raleigh, North Carolina now, and been here for, I guess, coming up on 11 years, which is hard to believe. And also work as a Blue Cloud Surgery Center provider and a regional dental director with Blue Cloud Surgery Centers. And practices Carolina Pediatric Dentistry. And when I'm not there or at Blue Cloud, with my family. So I got three kids and a wife, and enjoy spending time with them outside of work. So goals for tonight, just want to introduce what ReVIVE crowns are, why they were made, how to prepare teeth for ReVIVE crowns, some cementation tips thereafter, and just general tips for successful ReVIVE cases. So what are resin ceramic reinforced crowns? It's kind of a mouthful, but essentially it's a ceramic core with resin infiltrates that surround that ceramic core. The resin base gives a toughness and durability, and as well as a bit of a flexibility. It's easy to handle and gives really excellent aesthetics. And the ceramic reinforcement provides mechanical strength, long-term color stability, gives abrasion resistance, and an enamel-like translucency. So those things two together give a really aesthetic crown that can withstand the forces that children and adults can put their teeth through. And it's got a long track record with the material has a 30-year documented clinical use, so a long track record behind it. I need dumb ways to remember things. So this was an AI generated. I was asking ChatGPT, like, how does this all work? So you can think of it like the ceramic substrate is sort of the skeleton, and the resin tags again flow in and around that ceramic skeleton. And honestly, that's not dissimilar to our own skeletal systems. We have bones for rigidity and muscles for protection and strength. And, one couldn't exist without the other. And it's a great thing about these crowns is there is a little flexural resistance. So if sustain a trauma, or you have a bruxer who puts a lot of force on the crown, it'll flex a little bit, but the resin component of that can absorb some of that. So 3D printed, so they are made sort of from the ground up. They're metal free and biocompatible. So if you have a family that insists on being metal free, these foot the bill. There's less tooth reduction needed compared to, say, zirconia. It's very slight difference, but as you prep one next to the other, the Reviver requires a little less tooth reduction. It has a nice, clean, plaque resistant surface, so it's easily cleansed. Um, they have enhanced retention, so we'll see an image, but the inside of the crown is micro etched, so it increases the surface area for increased bonding strength. Cement compatibility we'll see as well. It's compatible with nearly all cements that we use in our day-to-day life and the practice of pediatric dentistry. And again, has that proprietary material with a long track record. One important thing to keep in mind is there's a universal design. So like the signature crowns, The centrals work on the left and the right, the laterals work on the left and the right, the canines work on the left and the right. So it simplifies inventory. And we'll see as well, you can recontour the teeth a touch if you want to add a little flair, a little anatomy to the tooth to make it look a certain way. It's highly fracture resistant, so it's been tested tremendously, put through 800,000 load cycles at 80 newtons of force, which is what most children are put their teeth through. And this is just to zoom in on the intaglio surface that has that negative space that cement can flow into and increase the bond strength. These are some cases from Dr. Matt Lucero, who is excellent. If you haven't seen any of his webinars or restore courses, he's really great and just shows a long track record. So he's also been placing these for a long time and had some good long-term cases he took photos of. And you can see they look great. These are about 11 months out, no fractures to date, and his practice and my practice either. And they've held up really well. And you can see there's, these children are not great brushers who are receiving these crowns by and large. And so the oral hygiene isn't great in these photos, but a little gingivitis, but much less than we see with some other crown options that will restore teeth with. Really like this slide. It just shows Revive compared to zirconia, signature, and strip crowns. So when would Revive be an excellent choice over, say, zirconia? And a big one's just when Medicaid coverage doesn't cover an aesthetic crown like zirconia. Some states they do cover, some states they don't. The Revive crowns are reimbursed under the code 2932 or prefabricated resin crown. Again, we discussed, but slightly less tooth reduction needed compared to zirconia. There's a universal design for easy inventory, and they're less expensive. Over signature crowns, if you have a parent, again, who needs or demands no metal, if you want it's superior aesthetics compared to the signature crown with the white facing on the metal core. There's a wider Medicaid coverage in select states and also less expensive. The Revive crowns are less expensive. And over strip crowns, pretty much every single circumstance, strip crowns look amazing the moment you place them, but as soon as they go home, they just can't, in most cases, cannot withstand the forces that kids put their teeth through. So it's so common we'll see a fracture or failure from a strip crown. And I find these are easier to place than strip crowns. They look better and they hold up better. So in pretty much every scenario, the Revive crown would be superior over a strip crown. Again, 2932 is the code for the prefabricated resin crown, and it's covered in pretty much all states. So there are a handful here you'll see is you're in one of those. Lobby your legislators to see if, or your Medicaid program to see if you can add this code because I think it really makes kids' lives better, and we'll see that aesthetically here in some of these images. This is a slide from partner work, Dr. Johnson. Left side is zirconia, the right side is Revive. And you can see zirconia has a little bit more sheen to it, perhaps a bit more elegant, if you will. But aesthetically, I think they hold up next to each other really well. Preparing, signature crowns versus the Revive crowns. Signature crowns to have the material bulk that is required, it really requires a lot more space. So you can see on the left side, just the bulk of material and approximately makes these crowns hard to place aesthetically, especially when there's crowding. Image on the right is preoperative, a child that again Dr. Johnson saw that shows just what you can do with these crowns, but really large caries, cervical lesions, subgingival, and a lot of hands. A lot of times these would be extractions, but was able to restore these and get good margins on these teeth and save this child's teeth. And you can see in the lower anterior in particular, just the crowns are much narrower, and the little bit of space really adds up and this allows you to get the crowns down largely straight. This is on online, so I won't bore you, but essentially the prep is just like a zirconia crown, just slightly less reduction. So incisally, you want to take off about a millimeter, facial half to a millimeter, on the cingulum, similar half to a millimeter, proximal about a millimeter, and then you want to go 1 to 1.5 millimeters subgingivally just to make a nice smooth feathered edge. As we discussed, we have universal left-right sizing, and I didn't mention, but the lower incisors are also universal. Have size 1 through 4. We also have mandibular canines and mandibular and maxillary canines, as well as the central lateral incisors have size 0 through 6. So wide span of sizes, and you can selectively polish these to get that left-right anatomy if you so choose. Here's a quick prep so you can just see what they look like or see what the prep looks like for these teeth. And if you aren't comfortable with this, your first time doing anterior aesthetic crowns, this video may not be the ideal for you. I might want to start with depth cuts, and you can see that on the right side if you want to scan those QR codes to some great lectures showing the depth cut method. This is used as a football diamond. So do your incisal reduction, engage the 1/3 tip of that football just along the gingival margin and do your bulk reduction, then throw a flame on, go subgingivally again, 1 to 1.5 millimeters, and make sure everything's nice and smooth. But do your circumferential reduction. Don't forget, especially the on the lingual, that incisal third. Don't neglect that area. I notice these crowns will hang up in that area if you haven't prepped it. The signature crowns will accommodate that much more so if you are light on your prep. But these crowns require that area be reduced. And then fill the crowns, make sure just air water blast, make sure they're nice and clean. You don't need to use any additional IvoClean or anything like that as you do with zirconia. But seat them, make sure they're in the right spot, exactly where you want them. This is using BioSim. So you do a flash cure for 3 to 5 seconds, peel that excess cement off, and then once all that excess cement is gone, uh, do a final cure. And it's helpful to use two curing lights for this, one on the facial and one on the lingual, and that'll really increase the speed at which you can move through a case and decrease the chair time for a child if you're doing these in the office. And then you can use that polishing point to go back and polish, make sure everything's nice and smooth and there's no excess cement. Great. So some prep tips. So it's again very similar to zirconia, less circumferential tooth reduction. As we saw in the video there, just place a small chamfer with a football course diamond, being sure to only make contact with the cervical third. Don't lose your resistance and retention form. So you want the taper to be less than 15 degrees. You'll lose a lot of your bond strength and retention to the crown if you really TP your prep. So just be mindful of that. And like zirconia, when you're done, the gingiva will look rough, just going subgingivally that millimeter, millimeter and a half. But these kids will heal up super quickly after the crown's replaced. Just make sure after the cement is totally cured, you want to go clean the margin where the crown meets the tooth subgingivally. Just make sure you don't have any excess cement hanging out along the margin there. You want a 100% passive fit, so you don't want any prematurities. And when you're fitting, don't push the crowns if you sense resistance. So any excessive force can weaken and fracture at the margin. Same thing happens with zirconias, but we'll see a picture here in a second that'll help to elucidate that. But just be mindful, don't, with these crowns, especially if you're used to placing signatures, you can really push through resistance and get that snap fit to lock in. And you don't want that. You want 100% passive fit with these. One consideration as you're learning to do these, give yourself some time. So, put, say, one case if you're seeing children under general anesthesia. Make one case, yeah, a shot at doing these signatures. Don't make every single one. Don't overpromise, especially if you haven't done these before. So give yourself, again, a case or two to learn the ropes. and don't overschedule yourself therein if you want to bite off trying these. Consideration, again, practice makes perfect. I mentioned that I think I hold the record for the kicking a soccer ball against the wall in the small county I grew up in. But this is my home, and I would kick the ball against the garage there, and just beside there was a retaining wall. So I'd kick it against the garage, against the retaining wall, against the garage, against the retaining wall. And there was collateral damage. It was Jack and Francis's cars next door, and occasionally I would, miss the wall and ping their cars. That's small potatoes. That's nothing to worry about. But when we're working with children, we want to be sure and be confident in the work that we do. So again, give yourself time. Don't put yourself under pressure and get yourself stressed out. And practice makes perfect. So the first day, maybe do one case of these, and then the next time do two, and the next time three, and work your way up to preparing these and getting some reps under your belt. And yeah, practice makes perfect. The more you do, the faster these will come, and eventually it'll just become muscle memory for you. As I mentioned before, don't push through resistance. This is, in my own practice, pretty much all of my crown fractures and failures, especially with zirconia, is pushing through resistance or cementing into resistance. So when you sense any sort of resistance pushing the crown down, even if it looks like you only need a quarter millimeter more to get it to match the tooth next to it, if you sense that resistance, just do a tiny little prep. It's usually, the tiniest, enamel rod or bit of dentin you need to remove to get the crown to seat. And this is not a NuSmile crown. So again, I have not had any crown failures from any of the Revives. This is a competitor's similar formulation crown, but this is how crowns fail. And it starts as a tiny fracture at the margin, and that force just propagates through the crown, and you end up with, in this case, it's the entire facial surface is off, but the lingual is still present. And so an ideal tooth prep is all nice and smooth. It closely matches the crown, just a tiny bit smaller so that you have a tiny gap circumferentially around the crown. As an image, what you don't want is this non-ideal tooth prep with a prematurity. You put the crown on, it seats into that prematurity. It may seat all the way, it may look good, but what you'll get is this tiny little fracture line that just over time through function will propagate through the crown. And the revived crowns can tolerate this better, but if your force is strong enough, it will be too much for the crown to accommodate with the resin infiltrates. And this is what it looks like when it fractures. So you'll get that one little point. It's kind of like glass or a windshield. And once you have that tiny point, that crack will just find the path of least resistance through the crown. So unless you want salty parents to pepper you, don't push through resistance. So what can you cement with? Really, any cements that we use day to day will work. So any resin modified glass ionomer like Biosim, Fuji Sim 2, you could use Keytech, any standard glass ionomers, they will all work. I personally prefer a resin modified glass ionomer, and I prefer that because I like for the crowns to be exactly where I want them. I want to cure them into place, and I want to be sure that those crowns are on and retentive before a child's appointment is over or before they're extubated if this is being done under general anesthesia. You don't want to see, especially under anesthesia, you don't want to see a child again to have to re-cement a crown because of incomplete cure or just a poor bond. So after you cement them, and especially if you're using or only if you're using resin modified glass ionomer, or if you're using Keytech or any other glass ionomer, make sure you do them earlier in the case. Cement, make sure you don't touch them as you're working elsewhere in the mouth. Give them the full time to set up that you can allow, and grab onto them and try to pull them off and make sure that they're on there good. Uh, NuSmile actually has a new product that I've been using as well that I really love called NuSim. Biosim can be a little more technique sensitive. I'll show you just what that looks like here in a minute because it's what I use day to day. But more and more I've been using this NuSim and really like it. It can be used with like under stainless steel crowns as well, and handles a bit like a hybrid glass ionomer, resin modified glass ionomer, even though it is a strict resin modified glass ionomer. Um, so it's nice. It has the dual cure for fast controlled workflow, and you can use one of these or one cement type for all of your crowns. Easy cleanup. It has great compressive flexural strength compared to other competitors. The dentin's adhesive strength is excellent. You get sustained fluoride release, great bond strength to enamel and dentin, and it's has low solubility, so just won't wash out over time. And again, handling is kind of like a hybrid between the resin modified glass ionomer like Biosim or Fuji and and something like Ketat. Um, so again, one cement for all crown types. It's less technique sensitive, and you get a fast and predictable cementation. Gives higher compressive flexural strength, excellent color stability under the crowns, and reliable long-term cementation with, again, that low solubility, so it won't wash out over time. I'll hit it one more time because it's so important. Confirm your passive fit, and when you're going to cement, just air water blast if you've been trying the crowns on and it's kind of a bloody mess. I think it's helpful just to have water on, say, a 2x2, and just let the crown soak in water so the blood doesn't dry and cake on if you're working elsewhere before cementing. Um, Once the crowns are clean thereafter, you can also use something like a cotton applicator just to get in and clean the crowns if there's dried blood or material in there. And I'll just air water blast and then dry really well the intaglio surface. As with zirconia, you don't need to use IvoClean or any sort of cleaning agent to get any proteins or whatnot out of the inside of the crown. Just air, water, and then air to dry it well is all it's needed. You can use glass ionomer, again, resin modified glass ionomer, and I prefer Biosim. Here's a quick link to Biosim info and the video, so won't bore you with that. Yeah, you have that at your disposal, and there's a lot of great resources on the NuSmile website if you haven't been there. I spent a lot of time as I was learning to do these things, and there, again, some wonderful resources there from other practitioners. After you cement, as we saw in the video, just tack cure once for like 2 to 5 seconds to harden the cement flash. Clean that up, and it'll bond together so you can take it off as one sort of glob. And so clean that flash off. Once everything's largely clean there, give it complete curing cycle. So in my own experience, common cause of failures is incomplete cure of the cement. So when in doubt, give it an extra little cure and ensure that you have that cement 99.9% set up before you start testing it. And again, 2 curing lights will speed up your workflow. After cementation, you know, that's where more times than not, trial the crowns on, they look perfect, they match, they're all perfectly aligned, and go to cement the crowns, and one of them's just rotated just so or just enough to throw your aesthetics off where you had it perfect just before you're trying. One wonderful thing with these crowns is you can polish off just tiny little spots to make the crown and sizal edges match. And I'll have a picture of that to show you in a little bit. So they have less surface hardness, so these polishing points, composite polishing points, can shave down a little of the crown structure, and you can get some superior matching that way. Also, be mindful of ambient room light. So, like our old office is all incandescent lights, and our the newer office and the Blue Cloud facility where we go, largely those are all LEDs, and they have more blue spectrum. So, if your packaging says you have a 60-second working time, if you have a lot of ambient LED light, it will reduce that working time. So, like an ROR suite, I'll turn one of the lights off, keep one of the overheads on, and work that way just to extend the working time. Adjusting and cementing. So adjusting the crown, again, you can adjust those with the polishing point. And then cementation, hemostasis is the biggest issue and question that we get a lot. So a few tips, just pressure, so 2x2 gauze pressure to slow down any bleeding. You can do tissue infiltration with a hemostatic agent, such as local with epi, and that'll give them a little postoperative comfort. You can use a hemostatic agent. I personally have not found the need to use that just with pressure and local hemostatic, so like epi and local. But that's another option for you. Just make sure you clean it off well before cementing. It's a quick picture. Just this is what you want if you're using local with epi. So you want good blanching of the tissue. You don't want to use too much pressure there, but you want that tissue to blanch, and you want to give it a couple minutes to work. You also don't want to inject right at the margin. You can get a little residual bleeding from the injection site. So move a little bit away, still in the attached gingiva, and just try to get some good blanching. Here's a picture zoomed out a bit from the one we saw previously of the intagular surface, but it just has those little islands. And so cement can flow into those little islands. It increases the surface area and increases the bond strength. Has very strong compressive strength compared to competitors, and again, also highly fracture resistant compared to the competitors. What it is not, so importantly, it is not the same as Bioflex. It's the same code as Bioflex, so the prefabricated resin crown, but completely different, different material. So it is, don't think of it as Bioflex anterior, and the crown prep is not like Bioflex, definitely more like a zirconia crown prep. So some cases here, I'll share with you some things, I think went well, some things that didn't go as well and learn from. And so they're all my dirty laundry here. So just one case I think that looks really nice, so before and after, putting crowns on D through G here. So pretty large carious lesions and definite aesthetic improvement for this child. Here, C through H, you can see it looks like they had some enamel hypomineralization on C and H, but the gingiva here, especially around H, it can look like hamburger after you finish, but that'll heal up. Give it 1 to 2 days, and it'll look as good as new. Another here, so this was a deep bite. I feel like in kids who are class two, like anytime you do, how do you say signature crowns, the teeth are just so much more noticeable. And so these Revive crowns have just superior aesthetics, I feel, compared to signature crowns, especially in just highly aesthetic cases when certain facial profiles are sort of just really prominent with those front teeth. And here's one from colleague Dory Beth Ruiz. This was the first case that she did. And these are awesome crowns. I mean, heck, they look better than mine. And I like to show just tooth number C here had a facial composite, and you can see the resin of the crowns really matches the resin of the composite on C there. Another thing you can do, so here's a case of Revive next to some Bioflex crowns in the upper right. And so this kiddo, unfortunately, D through G were all abscess, but tooth C, we did a Revive crown on, and you can see they had the constricted maxillary arch and prep this tooth out of crossbite. So preferentially prep the palatal of tooth C there and really push the crown to the facial. And when doing that, also reduce the R below it to reduce the interference point. And just looking at this case, after versus before, just unlocks their dentition and hopefully allows them to grow without that maxillary arch trapped in the mandibular. So again, you can do this with the anterior as well. Dr. Johnson had the picture previously, but you just want to preferentially prepare the lingual or palatal side, and you'll still need to do a little bit on the facial, but it'll kick those crowns facial. Here's another just showing that crossbite correction in the anterior. And so again, over prep the palatal and it'll kick the crowns to the facial. Another thing you want to do is just enamelplasty the incisal of the lower anteriors. If it's that pseudomaxillary class 3 where the top incisors are trapped below the mandibular, the kids will continue to grow and sort of outgrow that relationship. If they're true class 3 growers, then this may be a short sort of stopgap, and that mandible may continue to grow and outgrow the maxilla, and they may grow back into that class 3 relationship, but just gives them a shot to outgrow that. Recommendation is to photograph your work. I did not until I started placing these crowns, and I found it really helpful. And I wish I had done it so many years ago because it allows you to just really critique your work. And I noticed this highlights tooth F for me was my nemesis, and tooth F was just always rotated a touch, and realized just I wasn't adequately preparing. In my case, like the distal lingual. And so it really challenged me to improve my technique and improve my work. So again, just while you're working, snap a quick preoperative photo, postoperative photo, and just see what you can learn from yourself. Um, Minding the gap. So when you're removing the maxillary centrals, just be mindful of the sizing of the laterals. So I thought this looked pretty good, just doing D and G and cemented those guys down before making a mess and removing E and F. After removing E and F, I noticed that they're just way oversized. So I should have gone, size down. So when in doubt, I generally will recommend sizing down unless you've been aggressive with your prep, just because yeah, the crowns go down. You're like, okay, good, I got something to fit, but they don't always look the best. And sometimes it's helpful to just snap a picture and look at it, or take a step back and rather than being upside down, look at the child from uh, straight on. And a lot of times that can inform whether or not, or get another set of eyes, ask your CRNA provider, your dental assistant, what do you think about these? And find a lot of times, in my case, I'll think the larger size is the right one, and the smaller is definitely the way to go. And here's an example of sizing down. And so here, I knew that and prepared D and G and over prepped them down. And I just think it looks much better sizing down the laterals when you remove the centrals. Bruxism is just something to keep in mind. So here, E and F were fine. D and G had those mesial sub G caries, and I think I plastied the facial of C and H. But the Revive crowns have a little bit of curvature to them that kids with bruxism do not have. So a lot of times those are worn flat. With that polishing point, you can lay it sideways and remove that curvature from any crowns that you place, just to make them a little more matchy-matchy. Another consideration is the crown heights of these Revive crowns are set to quote unquote normal crown heights. Bruxers, we all know they're wearing their teeth down, sometimes significantly. So the marginal heights, there'll be a discrepancy when you place these crowns. And so just be mindful of that. I still think they're a superior restoration. Most kids don't have full gingival show, and even if they do, most people aren't going to notice those gingival heights being a little higher in the laterals. Here's the case of just a minor adjustment. Thought I had everything good to go, cemented, and I noticed F, again, F is my nemesis, was a little bit longer than E. And so one thing you can do is just take that little polishing point, uh, um, polish the incisal edge, so you can also do facial if it's rotated a little bit. Wherever it is, just apply that polishing point. It doesn't take a whole lot. And you want to engage the flat surface as I have it oriented there. You don't want to put just the sort of the curved end against the tooth, because it will leave a little divot. That being said, along the facial, if you wanted this to be more so permanent revives, which we hope to be testing soon, if you wanted to put a little facial anatomy so the light reflects off the teeth, say you're trying to match number 8 to number 9, you could use that on the facial to give just a little bit of facial anatomy and change the way that light hits the teeth. Singles and doubles here. So I put singles and doubles into AI and it's spit this image back. But it really highlights, AI is not taking our jobs anytime soon, but AI will inform how we do our jobs and how, our work is reviewed moving forward. And yeah, I think big data will come into play more and more over the years. So just being mindful of that. Used to be that with the signature crowns, you couldn't really match just one tooth. So, you want to do all four incisors at once. But as we saw before, the singles and doubles, that's not always indicated from a restorative perspective. And it was interesting. I was watching this one battle after another. No spoilers, but this is Sean Penn's character, and something unfortunate happens during the course of the movie, and he needs facial reconstruction surgery. And he has this awful, awful white crown in his mouth, the whatever prosthetic is prosthodont is made for him. And I think his character, it's intentionally done such that it is just bright, bright, bright white. But I could not see anything besides his character's tooth for the entire scene. And sure enough, went into work the next morning, and this is the one of the first patients I saw on the day, and it's like there's Sean Penn's character right here in the chair. So this is a signature crown. This was likely was indicated. I don't recall. I don't even know if we had done or if I'd done this work, but you just needed the one crown, but that one crown just sticks out so much more than the others, and especially if you're in say like a dark space or black light is in the room if you're at the skating rink or something, that tooth there, that one tooth is just so much more noticeable. And after I saw him, I was like, man, I really wish that was a Revive crown instead of a signature. um, but natural tooth match again, case here on the right, as I was saying, like I could never do just the two front teeth. I had to scour the internet to get this one image, just because they stick out kind of like bunny teeth. They're so much more noticeable. And the wonderful thing with the Revive crowns is you can do just the two central incisors. They'll match the laterals and the canine's great, and it's just a far superior restoration. And then with AI on the backside of that, if it gets to be one day where, there's some sort of audit and your images are sent in, or there's, live audits. I know in the state of North Carolina, there was talks of a health information exchange where at the end of the day, all of your records are uploaded to a central repository. I'm sure this day is coming where, some sort of AI is run on top of our records and it looks for matches between the radiographs that are on file and the treatment that's rendered. And so I really think Revive is a great option here because it allows us to place aesthetic restorations that are necessary and not place any restorations that are unnecessary. Again, this image is from before, but just to that point, you get really great natural tooth match. So this is this kid's teeth in repose, and I would put that on my iPhone lock screen if that was my kid and smile about it. Some more Revive cases. So again, just eight or E and F here, D and G are natural, and I think really good shade match and aesthetic match there. Again, with that bruxism, the teeth are a little bit longer, but if I did this all over again, I think this was an early case. I'd go back in with that polishy point and just flatten those incisal edges. Another case of bruxism. This is a tough one. The So this child came to see me at the surgery center through Blue Cloud. They were referred from hours away, and they'd been managed. D&E had been managed with SDF, and I think posterior had been managed with SDF as well. Just over time, the posterior lesions got larger. They were referred to the surgery center for comprehensive care. And so, what do you do with those lesions? They're under general anesthesia, they drive from hours away, the behavior is a challenge, and you don't really want to leave caries that could potentially progress. As well, you don't want to do composites and a heavy bruxer like this child. So we have the Revive crowns. Let's just place crowns on D&E. And the it's a decent shade match. But with that heavy bruxism, it's hard to get the crown heights to match. So I tried to give him a little gingival recontouring, and skeptical that that actually was effective. But again, with this case, looking back, I would have taken that polishing point and taken those incisals down a little more aggressively to better match F and G. And then the AI that we were all familiar with before 2025, 2020, or 2023, 24, 25, whenever that conversation started. But this is one of the most challenging, if not the most challenging case I've had in my practice life. Another referral to surgery center from hours away. Case of melogenesis imperfecta. Can see just heavy calculus buildup. The teeth are super sensitive, and child really had trouble keeping them clean. You can see the gingiva is just, yeah, fiery red, not happy, very swollen. Um, and just really complex. Got a crossbite number 7 with 26. Some other images here, just all the premolars are affected. It had some previous restorative work done. Um, and with that restorative work, had some crowns placed on the 6-year molars. If you squint, you can see like number 30 has recurrent caries almost to the pulp, and tooth number 4 is ectopic there. So really complex case. We don't need to get into the orthodontic considerations, but this child came to see me and it's like, I don't know what I can do for him. You could try to do some strip crowns. That's going to be a total nightmare because his gingiva is just going to be, yeah, untamable. And so instead of placing, composites or strip crowns, and instead of placing permanent zirconias that would require a much more aggressive preparation in a child that's still growing, fortunately, thinking outside the box with colleagues, decided to pull out the ReVIVE crowns. And so, in this child on 23 through 26, used the permanent lateral incisors for those lower anteriors, and then on 7 and 10 on top was able to fit the some central incisors on those two laterals, and prepared that tooth number 7 out of crossbite, um, and just allowed this kid to grow for a little while, and ended up taking his 6-year molars out just to relax some of the crowding that he had. And then I covered up. I don't like the look of 8, 9. They're too dark compared to these, and I don't love the shape of them. But said the DOJ can do it, so I can do it. But this is what those guys look like. The parents were thrilled. I was not thrilled. I wish we could go back and yeah, make these perfect, but allows this kid to grow. He's going to need braces. He's going to need a lot of work as he gets older, and he'll be back to replace some of these crowns and cover up his premolars in the future. But this is one just thinking outside the box. So thinking if there's a bad trauma and the child doesn't tolerate having, a fragment rebonded and just need to cover the tooth back up, a Revive crown could be the answer for them. So just having these on hand, I never thought I would use them in the permanent dentition, but they work great in this case. Again, a little short on number 25 there. It has a little show at the gingiva, but this kid will be back for comprehensive care just in the future. And when I think about Revive crowns and I think about sort of what I do as a pediatric dentist and what I want for patients, I really like this. I mentioned before, but I want to give parents treatment that they'd be happy to take a picture of and have their child's picture on their phone lock screen, and not look directly at their teeth and be like, oh yeah, they had to have those crowns put on. The children that we treat, they don't choose the parents, and the parents a lot of times don't choose the circumstances of their lives. And that's why I think these crowns, these Revive crowns, really make the world a better place, because anymore I find them easier to place than signature crowns. I think they look a whole lot better, and I enjoy placing them a lot more. And in North Carolina, the Revive crowns are reimbursed at a lower rate than the signature crowns. But again, I believe in the product. I believe in delivering a superior result for families, and so I just do them at a reduced rate. But I think it's what's best for others, and the rest will take care of itself. Um, So there's a starter kit. There's a starter kit and a professional kit. I would recommend the professional kit. Again, just you never know what size crowns a child may need. You may have a child with, really tiny teeth, or another with really large teeth, and it's helpful to have the full spectrum of sizes to work with. And even again, outside the box, just having the sizes available if you need them for a permanent tooth for some reason. Um, I personally would recommend the professional kit, but the starter kit will serve you well if you want to try them and get some reps under your belt and see what they're all about. If you want to do hands-on, so if you don't want to kick a soccer ball at your neighbor's car directly, and you want to try these crowns and practice preparing bench top with instructors. There are a couple courses. So there's one coming up in Chicago. I think that one's sold out, but there's a wait list if you'd like to attend that one coming up in Chicago, and then another thereafter in Los Angeles. And these are a lot of fun. They're always in fun places, and all the courses that I've attended, it's just a great group of people and a fun weekend. And so a couple options for you if you'd like to do that. And thanks everybody for your time. And I'm happy to answer any questions if you have any, or clarify anything if anything was unclear.
Thank you so much, Dr. Morris. We have about 14 minutes for questions, so just go ahead and drop them in the question box and then we'll get them answered. Do have one question already. What do you do with the crowns you've tried on but choose to not use? How do you sterilize?
Great question. So you just want to clean them. So you can all just air blast them, or you can use a like a cotton tip. Just make sure they're nice and clean before you put them through the sterilizer. But you can throw them through an autoclave and they'll be just fine. If you autoclave them multiple times, you may get like a little bit darkening of the shade. I personally have not seen it, but that's what we do in the office and surgery center. That's what I would recommend.
All right. While we wait for questions, I just wanted to remind everybody that wasn't here towards the beginning of the webinar that you do get one CE credit for tonight's webinar. You'll be getting a little survey from one of our events team members, probably Zoe, with a little survey. You'll fill that out and then she'll send you your CE certificate probably in around 24 hours. And then also we do have a sale going on the Revive Crowns, the professional kit that Dr. Morris was talking about. It is 20% off. So you can reach out to Brittany. She left her information on the chat box if you guys were interested in that. Just a couple more minutes. If we don't have any questions in like 2 minutes, we'll go ahead and call it a night, but we'll just give everybody like another minute or two.
And while we wait, I should mention this earlier. For keeping the teeth nice and clean during the cementation process, I find it helpful just hold the air water syringe and have a 2x2, say in your left hand. I'm right-handed. 2x2 in your left hand. Pressure hemostasis, especially when it's difficult to get good hemostasis, and blow the air water syringe like down the long axis of the tooth. So quick blast with water to get any sort of debris off, and then hold the air on the tooth you don't want to desiccate the tooth, but you want it decently dry. It'll bond better to dentin if it's not fully desiccated, but just get the tooth nice and dry and have your assistant, load the crown and, take the crown, place it directly. And that I find is the best way to keep the tooth isolated, especially when heme control is a challenge.
I was muted, but we do have one more question.
Sure.
Okay. Do you find that local with local with epi works best compared to aluminum chloride 25%.
I do. So I find that the aluminum chloride, like it can stop bleeding sort of temporarily. If you've got really severe gingivitis, it can stop it for a moment, but as soon as you wash the tooth off, as I was just describing, you're going to induce the bleeding again. So I really think the pressure hemostasis and having you're really controlling the heme there with the air water syringe with the pressure, that's the way to go. And doing that, a few minutes after injecting say lidocaine with epinephrine as demonstrated in that image previously. So you get good blanching, give it a couple minutes to work. That in my hands, I found is the most effective to control the bleeding. And sometimes too, it's helpful just do two teeth. So do, E and F, get those guys on. So seat them, make sure they're oriented as you want them, cure them completely, clean them up, be mindful not to stir up too much of the gingiva proximally just because you're then going to put the crowns on D and G. But sometimes you just have to go like one tooth at a time and work your way around, or two teeth at a time. So do E and F and then do D and then G, and then you can do C and H. Importantly, too, when there's crowding, just try the crowns on and have the order in your mind that you've tried them on and that they fit. So sometimes it's the canines, the laterals, and the centrals. Sometimes it's the centrals, the laterals, and the canines. Sometimes it's the centrals and canines and then the laterals. But just whatever order you cement the teeth in, or you could do canine across to the other canine. Whatever order it is that you've tried them on, especially in the cases with crowding, just make sure you have that mapped out in your mind and cement in that order. Because sometimes it can get kind of tricky getting them all to fit. And I don't have a shit. I'll work on getting a photo of this, but the other really nice thing with these Revive crowns is you can adjust the margin. So if you are trying to fit your crowns and you've got D, E, and F, and you go to do G, go to cement G, and it just doesn't go down. One trick is you can take I'll use like a diamond flame, and you can adjust, say, the distal margin of F and just thin that margin there, and that can provide enough space to get G down, and it won't compromise the integrity of the crown.